So pancreatitis is a itis of your pancreas, which is easy, is not a wrong answer, but it's not an infection. So there's no infection happening. Can you develop an infectious pancreatitis? Yes, but it's usually after about 10 to 14 days is where you'll have a pancreas that will start getting, not inflamed, but it'll start getting walled off and start getting necrosis that will develop in the pancreas itself, and that necrotic tissue is just prime area for bacteria to grow. But the first, 7 to 10 days, 10 to 14 days is really about not aseptic, but sterile inflammation, right? When we talked about sepsis, right, we said there was SIRS and there was sepsis, right? And there was overlap, right, between the two, right? So you had like SIRS on this side, you had sepsis on this side, and you had overlap in the middle, right? Where you have some patients that have infections. I guess better to say that this is infections more than anything else. But anyways, I think I'll point that out again during the slides here. But SIRS can be a systemic inflammatory response syndrome. I shouldn't use a circle to make the Venn diagram confusing. But SIRS is a systemic inflammatory response, right? That is systemic, and because of some kind of inflammation. One of them is pancreatitis. One of them is like trauma, like in a motor vehicle accident or stabbing or something to that effect. And like burns are on there. There's other things that are just independently make your body go haywire, okay? And there's no source of infection. When you have a source of infection or suspected source of infection, then you can say it's sepsis. But if there's no source of infection, then it's just SIRS. Do they both have the same consequences? Yes, they both lead to end organ damage, multi-organ failure, DIC, ARDS. They all have a lot of problems that can develop, right? So pancreatitis is one of those that is not an infection. It can have infections down the road, but the first 7 to 10 days is going to be a inflammation of the pancreas that's making your body go haywire. And why is it going haywire? Because your pancreas is literally eating itself alive. And that would make my body go haywire too if one of my organs was self-digesting itself. Right? So we have acute pancreatitis and we have chronic pancreatitis, and we'll talk about chronic panc at the end, right? So, but acute panc is the one that is going to be causing a lot of problems that we want to catch on pretty quick. And we're going to kind of touch on nutrition a little bit is with pancreatitis as well, because there's a lot of things in GI that have changed over the last 20 years that we're still seeing that have not come into practice. Like MPO is one thing, and like giving morphine to pancreatitis, you all know I can't get morphine. It's going to make the sphincter rhodea contract. It's going to make their pancreatitis worse. That's complete hogwash. It doesn't make any. It doesn't. That makes sense physiologically. Oh look, I gave it in the lab and made it contract. Doesn't worsen their outcomes. Doesn't make anything difference, right? Same thing with like being MPO with pancreatitis. Like, oh, you got to do some bowel rest to make them MPO. It's not going to actually improve. It doesn't improve anybody's outcomes. And actually, when you make them MPO, but when you do feed them, it improves their outcomes. It improves their mortality. So you're still going to see these trickle in here and there. So this information might come to light in like 5 years, hopefully. But we've known this stuff for a long time, that these are the better things to do things. So as far as like all the systems that have changed over the years, GI has changed the most as far as like evidence and changing practices. So you're gonna hear some like crazy things. You might suggest it when you have like some new guys, new intensivists that come in. You say, oh yeah, of course we're gonna do that. But you have like older physicians that have practiced in the 90s, 80s. They're gonna have some more older practices that might take a little bit more convincing to get it changed. So pancreas physiology is a review of the physiology of the pancreas. It has two functions, primarily the endocrine and exocrine. Endocrine, we'll talk a little bit in endocrine, right? Where we talk about diabetes and such. All right, so our beta cells secrete our insulin, right? We got little beta cells over here as well, secreting insulin into our bloodstream, right? So here's that's a duct, but we have into the bloodstream, we have insulin, which is going to do what to our blood sugar? It's going to lower our blood sugar, and then we have from our, it's our beta cells or alpha cells secrete what's the word I'm looking for glucagon, which does not make your glucose go on, unfortunately. It doesn't make your sugar go low. It makes your sugar go high. Glucagon. I don't know how to make glucagon work as a mnemonic, but glucagon makes your glucose go up, and insulin makes your sugar go down. They misnamed it, and nobody wants to take fault. All right, they should have named insulin glucagon to begin with. It would have made much more sense. Either way, these guys are going to normalize blood sugar, right? And we introduced with GI bleeds, we introduced octreotide. Right, is another thing that will raise your blood sugar as well. And octreotide is secreted from your gamma cells over here. We produce some different endocrine such, right? There's our somatostatin right there. Gastrin gets released as well. in response to cholecystokinin. CCK is a hormone that gets released that stimulates the pancreas to secrete its enzymes. It also tells the gallbladder to secrete its stuff as well. The gallbladder, in part of digestion, is going to help us absorb fats, right? So that's the step one of absorbing fats, is have bile in the small intestine right here, right? So there's our bile, which has all of our goodness that we'll talk about with gallbladder stuff. And that will help us emulsify fats and absorb it, but we can't absorb it until we break it down. And that's where we've secreted into our pancreatic duct some different enzymes. One of the enzymes being like lipase, for instance, which is going to ase lipe, right? Or ase is just an enzyme that breaks stuff down, and it's going to usually tells you, hopefully tells you what it does in the prefix, but lipids, right? Breaks down lipids. So not only does our pancreas create enzymes and secretions that don't go in the bloodstream, because if something in the body secretes something into the bloodstream, it's always an endocrine organ or endocrine gland. If it secretes anything but it secretes anything but into the bloodstream, like it secretes into the skin, it secretes into the uterus, it secretes into the GI tract, then it's called a exocrine gland, right? So we have the exocrine function of the pancreas and the endocrine function. So one of the exocrine functions was lipase, right? Another function was secreting other things we want to absorb. We want to absorb proteins, we want to absorb carbs, and we want to absorb, or glucose, and we want to absorb fats, right? So those are our 3 building blocks that we need to survive, right? We need amino acids from proteins, we need the cholesterol and fats and that we're going to reprocess in our liver, but we're going to take the fats in that we need, and we're going to also take in the glucose that we need. Amylase is one of those enzymes that will break down complex carbs like fructose and sucrose and other fun stuff, other starches, right? Other pastas and other things that are complex, and to more simple things that we have little receptors all along our GI tract that we can then absorb into our bloodstream, right? So that's the goal of this exocrine function of the pancreas, is to digest things, right? Proteins, fats, and carbs. Also secretes bicarb, because what just came from the stomach was a wash of hydrochloric acid. So to make sure our duodenum does not get ulcers, and make sure we don't get breakdown of our stomach, our GI lining. So bicarb is going to help neutralize all these incoming stomach contents, which is nice, right? But so this trypsin is an important protein. There's other enzymes in there too, but trypsin's our main one that's going to start breaking down proteins. So the problem comes when these enzymes get activated ahead of time. So usually you are producing enzymes, make their way all the way down, they can go down the pancreatic duct, all the way into the common bile duct, which we'll talk about a lot with gallbladder, and eventually get squeezed out the sphincter of Oddi, squirted out there into the duodenum, and they're going to then, so there's a little duct right there, produce all the our enzymes, and they get secreted into the duct, right, via all the exocrine glands of the pancreas. But what if those enzymes get activated early? Well, now what's made of protein, fat, and carbs? The pancreas. So you're going to start auto-digesting your own pancreas if those enzymes get activated early. Sometimes it's idiopathic. We have no idea what caused it. It's like 10 to 20% of the time. I have no idea why your enzyme decided, you know what, today's the day, trypsin, we're going to activate early, right? They get a false start, and all of a sudden this pancreatic juice gets activated ahead of time, right? There's some other known causes as well that we'll talk about that are going to, make our amylases, our lipases, and our protein breakdown happen earlier than it should. So gallstones, up to 75% of the time. Like I mentioned, we'll talk more with gallstones in the gallstone chapter, but we have gallstones that are produced by where's my green at? We've got gallstones. I've got a gallstone lodged right there. Hasn't made its way down into the GI tract just yet, right? My gallbladder produced it. It puts a little gallstone, it produced all the way in there, and it got stuck. Well, shoot, now my pancreatic enzymes are trying to get out, and also they're going to the same place, right? They all merge traffic together, and now the gallstone is lodged there. Now those pancreatic juices are going to get activated. It's like, you know what? They're going to start honking their horn. They're going to start activating themselves ahead of time, right? They're going to start getting some road rage and start digest themselves. So they played themselves, really. So that is going to cause a auto-digestion of the pancreas, right? So we talked about idiopathic, and then there's gallstones. So the mnemonic is I get smashed. That is the mnemonic. There's a lot of causes of pancreatitis, right? You just want to know like top 5, but there is a lot of different different reasons why your pancreas can get digested on its own, right? But it's all due to the activation of these enzymes before they should be, right? They should get activated once they're in the GI tract. Once they're in the GI tract, perfect. That's where I want you. That's where I want this to, where you to start working on the meal you just took in, right? But if I have a gallstone right here, for instance, right, that's going to activate my juices ahead of time. Okay, so up to 20%, 25% is often unknown, or what's the fancy word for that? Starts with an I. Idiopathic is different than iatrogenic. Iatrogenic is oops, and idiopathic is right? So those are but it doesn't look good on a chart. It doesn't look good when you talk to patients. That's what you have. You say, no, you have idiopathic pancreatitis, right? You have iatrogenic fluid overload, right? Oops, right? We gave you too much fluids, right? There's a more civil way to talk about it. Okay, but besides those top two reasons, is a ETOH, right? So ETOH. Number one, gallstones. Number two, ETOH, and number three is right? So number two is alcohol, right? So alcohol intake. So alcohol intake will specifically damage, yes, the liver and all kinds of other stuff, can make you at risk for colon cancer, all kinds of cancers, but it also puts you at risk for your pancreas getting activated and activating things before it should, right? So we have alcohol, right? Toxic metabolites build up, activate the pancreatic secretions, and those secretions are going to start digest the pancreas, and then your pancreas is going to go haywire, and it's going to start causing a systemic inflammatory response syndrome, right? And that's going to cause a widespread inflammation through the whole body and cause profound dehydration, of course, and lead to severe pain, right? It's going to hurt when your organ is digesting itself. So it's going to cause pancreatic pain. And where the heck's the pancreas located? It's usually epigastric, maybe a little, because right below the stomach, right? It's right retroperitoneal to the stomach. And also might, if it's at the head of the pancreas, right? Or it could be the tail, right? The head is where the duodenum is. If it's the tail of the pancreas, then yes, it might be the left upper quadrant, might hurt as well. But you get this epigastric, severe epigastric pain. It will radiate to the back as well. And it's like band-like, and that's a classic pancreatitis kind of pain. And yes, we get a fever. That's part of the surge response, right? We're going to tachycardic tachypnic. We're also getting white count elevation. We're also maybe get a little fever as well. All right, so those are all what happens from SIRS. What else can do it? Well, if I have trauma, right, I get stabbed in the pancreas, that will cause my pancreas to get upset and start activating itself beforehand. And steroid use, chronic steroid use can definitely put you at risk for pancreatitis. Mumps is a reason, and autoimmune diseases attacking the pancreas. Cancers can do it as well. Scorpion bites put you at risk for pancreatitis, not spider bites, but scorpion bites. And then hypercalcemia. So high calcium levels put you at risk remember what calcium does in the brain, right? It just arrives up on the Six Flags bus. It's like, let me in. You guys ready to party, right? So it's going to arrive when it's hypercalcemia. They're going to be knocking at the pancreas door, say, hey, can I come in? Can I activate the zymogens and the trypsin just yet? And then they say, and then when it gets overflowed and like a mob, like a Black Friday situation, all the calcium is going to enter and start activating everything, including the enzymes. So your pancreas will start digesting itself, right? So hypercalcemia will do that. And then once you've exposed the pancreas, the fresh raw pancreas to the bloodstream, those are just lipids, right, that you expose it to because it's a fatty organ. And now calcium is going to want to bind to the fatty lipids, and you can actually get hypocalcemia. So it's kind of finicky. It's like, well, does hypocalcemia cause it or is hypercalcemia? You got to think of calcium as the one that activates it. And one of the results of pancreatitis is low calcium. So high calcium causes pancreatitis, and one of the complications of pancreatitis just in general is low calcium. Okay, so ERCP. ERCP, we'll talk about with gallbladder stuff. When we have a gallstone, right, that's located right there, that's blocking the passage, we can do a little ERCP, and we can just take the little stone out, right? Perfect. It's going to fix pancreatitis. But just by surprise, it also causes pancreatitis. So it's like a catch-22. So gallstones are super popular, right? And they can be managed with an ERCP, right? Endoscopic retrograde cholangiopancreatography. If you want to impress your nephew or niece, or I know a big word. So that's a ERCP will go in there and it will fix a gallstone pancreatitis. But ironically, it can also induce pancreatitis. Okay, and we have different drugs, and of course pregnancy can put you at risk as well. So there's different, there's like a top 10 drugs that can damage your pancreas. So these are all things, right? I get smashed again as a mnemonic because there's so many things that can cause pancreatitis. One of the things I didn't mention was not only hypercalcemia, but also hypertriglyceridemia, which is like, I think like 4 to 5% of pancreatises. And we'll talk about that in more detail, but basically when you have super high triglycerides, it's not really sure why it happens, but it can activate your enzymes ahead of time and you can start digesting yourself. So actually here's an example of an ERCP where we go in there and we're gonna go ahead and we go into that little duct, bloop, and we're gonna go ahead and pop out that gallstone, and that just relieves everything that's backed up behind it, pancreatic juices and bile as well. Okay, so ERCP is great as one of the fixes for gallstone pancreatitis. Gallstone pancreatitis is a very, very popular, most popular, up to 75% of our pancreatitis. So diagnostic tests. What are some diagnostic tests we can do for pancreatitis? How do you know someone has pancreatitis? Well, we know that there's enzymes that get released by the pancreas, right? We had lipase, we had amylase, we had trypsin, you have zymogens, you have all little pepsins in there too. There's all kinds of enzymes that we could test for. So they did the research, right? And they said that lipase was the better one, right? It doesn't, it rises and it is very, very predictive of someone having pancreatitis. And it's basically 3 times the upper limit of normal. I always confuse it. Is it UNL or ULN? Is it upper limit of normal or is it upper normal limit? Or is it upper, it goes back and forth. Either way, it's 3 times what it should be. That's pancreatitis. There's nothing else in the universe that makes your lipase elevated like that. There's some things that make your lipase 2 times or 1 times the upper limit of normal, but nothing else, right? So there are other reasons for lipase, right? You got some intestinal stuff going on. You got biliary disease, renal failure because you're not getting rid of it, right? You got lipase is not going away. Diabetes, DKA can make your lipase go up. You got any other kind of pancreatic disease can also make your lipase go up. But when you have a lipase that's 3 times the upper limit of normal, then there's nothing else that's going to do that. So you only have to check it once, right? You'll have people say, oh, let's order another lipase, or they got pancreatitis. You want to trend the lipase? Because we're used to they have a GI bleed, you trend the hemoglobin, right? You only have to do 1 lipase. That's it, right? There's no other difference to do lipase again. Once you have pancreatitis, you have pancreatitis, right? You can't say in 3 days, maybe the pancreatitis is not there anymore. No, if it's more than 3 times, if lipase is greater than 300, 200, 250, 100%, you got pancreatitis, there's no reason to check it again, right? You have it, you can't get rid of it. You can't deny that lipase was elevated. There's no other false positive lipase elevation. Okay, so lipase is 3 times the upper limit of normal or the upper normal limit, and that's like 90% sensitive for pancreatitis. You have it. When they did the research and they said, hey, we checked amylase, we checked lipase, and when we did amylase, it was only like 50% on the low end, 80% on the high end. So you can see that's why amylase has fallen off. Right? You don't just suggest an amylase. Amylase shouldn't be done. There's no good reason for it, especially in the ICU. There might be some rare situations, but that's the idea, right? It peaks and it kind of levels out, and it will be there, and it will detect that you have pancreatitis. It'll sit around for, I think it was 8 to 12, where is it at? How long it stays around. But it's going to then be a way to assess if someone has pancreatitis in the last 3 days or the last 8 days, right? And another piece about lipase, not only, if they have it, but like if your lipase is 1,000 and your lipase is 10,000, there's no difference in mortality, right? There's no difference like, oh, you got 10,000, you're super, super sick. Just like with the troponins, right? Troponin of 1,000 versus troponin of 40,000. Someone with 40,000 is much, much higher risk of dying, higher mortality, right? Unless they went to cath lab, and that's the reason why the troponin is elevated. But there's some labs that are like that, where the higher the lab value, the worse off they are. Like rhabdomyolysis, the higher your CK level, the worse off your rhabdo is, the worse off your mortality is, right? But with lipase, that's not a thing, right? Once lipase is high, it's high. And then we know your pancreas is digesting itself, and we got to fix it. Okay? And since you're digesting yourself, you're going to have abdominal pain. So basically they did some research and they said, hey, how do you know someone has pancreatitis? They said any 2 of these 3 things, you got pancreatitis. Lipase is 90% accurate. And if you have lipase elevation and you have abdominal pain, that's epigastric in region and it's kind of radiating to the back, well, shoot, that's pancreatitis, right? So they will have a lot of nausea, vomiting as well, along with their abdominal pain. All right, so just those 2 things, you really don't need a CT scan, right? Especially like in a cash-strapped area that you can't do a CT scan on everybody, then there's not really a good reason. But if they don't have the belly pain, like they're intubated and sedated, and you can't really get a good abdominal pain assessment, but you got lipase of 2,000, Well, do they have pancreatitis? Well, lipase is going to definitely lean me there, but I can get a CT scan to assess that they have a pancreatitis brewing. And what it looks like on CT scan, it looks like an itis. It's inflamed, right? So the pancreas is inflamed on CT scan initially. So the reason why I say initially is because the complications of pancreatitis, they can develop into cysts that develop and further inflammation, and they can lead to necrosis as well. So a CT scan can look for early pancreatitis, but also late, you can look for necrosis and pseudocysts that might develop. All right, so pancreatitis will inflame, and you can see how bad it is, and your lipase is going to be, in addition to your CT scan, will definitely tell you have someone with pancreatitis or not. All right, other labs you might check that would kind of be worried about or following up on is calcium. We know that if we do labs with someone with pancreatitis, the calcium comes back at 14. Well, shoot. That might be the reason for your pancreatitis, right? Other reasons would be doing like an ultrasound of the right upper quadrant, as we'll learn with gallbladder stuff. That's actually better than a CT scan to look for gallstones. And we know that gallstone pancreatitis is up to 75% of our pancreatises. So that's something else we might do in the meantime to see where is the pancreatitis at, right? I don't know if you'd be looking for scorpion sting bites, but you'll be looking for, definitely looking for gallstones. You look for history. If they're intubated, you can ask the family or what's their drinking history to see if that's the reason why they have a pancreatitis in front of us right now. Another reason that we can get on labs that would explain their pancreatitis would be their triglycerides, right? So triglyceride level, if it's more than 1,000, you're very, very high risk of having pancreatitis, right? What's one of the drugs we give that can raise your triglycerides?
Probe.
Yeah, so probe can also raise your triglycerides, and usually when you're greater than 500, you're at risk for pancreatitis. If you're greater than 1,000, you're just asking for it. Okay, and the other thing is that with propofol infusions, we check triglycerides, right, every 3 days at least, especially if you're getting high doses of propofol, like more than 25 mics. All right, that's a good reason to be checking triglyceride levels. Okay, and going back to calcium real quick, that high calcium causes pancreatitis. It's rare, but it's also rare to have high calciums. Usually high calciums are associated with like bone cancers and bone metastases. But if your calcium is high, that could be causing the pancreatitis. But definitely with any kind of pancreatitis, once you've exposed that lipase and it sort of eats at the pancreas itself, it starts forming these lipids that are available in the bloodstream, and calcium is going to want to just soak up that sun, right? It's going to go ahead and attach to the exposed pancreas. That's these molecules that are negatively charged, right? Triglycerides are 3 fatty acids attached to 1 glycerol, right? Glycerol I think is negatively charged, and the other ones are positive charge. So it has charge on it, a little negative glycerol molecule. So the calcium is going to want to just hook up real quick. So it's going to bind with the free fatty acids. And then what else? So LFTs, all right? So LFTs will also be elevated, especially if like a gallstone situation. And we talk about gallstones, this might make a little more sense then. But as we have a gallbladder that is backed up because of a huge stone that's in the way, there's not only 3 tracks happening here. You got the pancreas over here, and you have the liver over here. And if we're blocked down there, that's going to cause a irritation of the liver, right? Going back up, the liver's involved over here. And will this make more sense when we talk about gallbladders? But if for AST, ALT, those start rising, especially the ALT, that's a trigger for liver damage. Okay, and of course T-bili and alk-phos will also be elevated, which we'll talk about more with gallbladder situations. All right, so again, alcohol, gallstones are your number 1, number 2 reasons for pancreatitis, and there's different drugs out there. ACE inhibitors can do it, Flagyl can do it, and sulfa drugs such as like Lasix can do it as well. All right, there's idiopathic, up to 25% of the reasons why we have pancreatitis. Don't know. It's up to 1 in 4 have no idea what caused it, but we can bet it might be gallstones or alcohol. Triglycerides, you mentioned, 500 is a risk. More than 1,000 is very, very, you're asking for pancreatitis. There's autoimmune genetic reasons, right? ERCP, about 5% of our ERCPs can lead to pancreatitis in of itself. and they did some research. I'm not sure whose idea it was to give rectal NSAIDs, and they said if you get a rectal NSAID before your ERCP, you'll have, or post ERCP, right? So since we went to the front and did ERCP, let's go to the back and give NSAIDs, and that will then cause a reduction in the amount of pancreatitis that might occur. Probably because they're NPO post, maybe that's why, right? Since you're under the midazolam or the Versed infusions, like, hey, let's go sneak something in there real quick, okay? You won't remember. You have amnesic properties of the midazolam, all right? And then what else? There's infectious reasons, like we talked about mumps and such. There's different toxins out there. Trauma, right? Blunt trauma, especially MVAs. We talked about hypercalcemia, activating enzymes, right? And there's other weird tropical reasons why you might get pancreatitis. And again, we only need 2 of 3 reasons to say that someone has pancreatitis. They got the classic abdominal pain, they have a CT finding, perfect, you got pancreatitis. But usually we're going to do labs and we get a lipase level, right? Lipase, that is not amylase, but a lipase is greater than 3 times the upper limit of normal, then that is pancreatitis, and not until proven otherwise, it's just pancreatitis. Or there's nothing else that will explain it. All right, so what else? So we got all kinds of other things we're going to look at. We're going to do ultrasound, make sure the gallbladder's not involved. We'll look to see if they have like liver cirrhosis and E2H history and E2H level even. Could tell us if we have like an E2H reason, and look for other rare infectious reasons are also on our with things to investigate. Also, in the previous slide, I talked about the high lipids. It also interrupts your labs. Your lipids are more than 1,000. Your labs are all messed up. You can't get, in the bottom left corner there, you can't get any kind of good read on your lab. So you have to do a send out, or you have to do a special test to be able to assess your accurate labs.
Will that automatically be triggered, or?
They'll see it. They'll see that the blood is very, very lipaceous, right? It's very, very lipid laden. So that's something they can say, oh, these are not going to be great labs.
So we can trust the results by the time we get
yeah, when they correct for it, yes. All right, so types of pancreatitis. All right, so we have interstitial edematous pancreatitis. That's 90% of your cases. That's where you have a pancreas that is inflamed and it is going to fill up with fluid, right? And wherever your body is inflamed, like we mentioned with GI, sepsis and such, is wherever you are inflamed in the body, that's where fluid is going to want to go, and it's going to want to leak even more, right? If you start giving normal saline, LR, your favorite fluid, it's going to leak best wherever there is inflammation. So they're used to, as we'll talk about with treatment, we do know they're going to lose volume, but we're not going to overdo it with how much volume we give these patients, because all that volume is just going to go to the pancreas and it's going to get inflamed more. They already have an edematous pancreas. Making it more edematous is not going to help their recovery. All right, so diffuse inflammation, right? The panc is intact, but it's not it's just very, very swollen. When it doesn't become intact, when it's going to be starts swelling to the point where it's going to start bursting through blood vessels, you start getting hemorrhages that are forming, right? So that's called a necrotizing pancreatitis, which is a hemorrhagic pancreatitis, where we've started eating through not only the lipid soft layer of the pancreas, but we also start eating through the blood vessels, right? Blood vessels are made of collagen, which is the protein, and guess what? I have trypsin that is activated that can eat through that, right? So I'm going to start getting eating through those blood vessels, but what else makes those blood vessels weak and what makes them start to break down more? Just like when we had ischemic colitis, we had lack of blood flow to the GI tract, and the GI tract started getting necrotic and started breaking down and sloughing off, and then we started bleeding into our GI tract. The same thing in the pancreas. We start getting a lack of flow to the pancreas, because why would that happen? Well, when I have a surge response, I get widespread hypertension, hyper or hypotension. When I get widespread surge response, what will happen? Systemic inflammation leads to hypotension. The blood pressure is going to drop, and that's going to potentiate a necrotizing pancreatitis. Right? And again, you can see this on CT scan, that there's necrotizing situation happening, or there's just edema and inflammation happening. All right, so there's gray Turner sign and there's Cullen sign. It's extremely rare for necrotizing. It's not rare, but it's for you to see it. When you see this, you know that's pancreatitis, but it's not as common as you were told in nursing school, right? So it's not like a oh, you got gray Turner sign, oh shoot, right? So you're rarely going to see this. I've probably seen it like 3 or 4 times in the last 15 years, right? So it's when you have a hemorrhagic pancreatitis, which is only 10% of your pancreatitis, and then if it leads to a significant amount of bleeding, you'll see the bleeding on CT scan. You'll see it show up there. but it's to the point where it starts hemorrhaging out into the retroperitoneal space and causes significant bruising. That's going to take a lot of effort for that to happen. Or they have to like been muscling through this at home for like 3 days, right? It's like, oh, I guess I'll go in now, right? It's like when you're working like in a rural area and the farmer comes in, it's like serious situation, right? That's when they really are dying. So that maybe that's where you might see it more. Okay, and colon sign CU is around the umbilicus, right? I hate when people say umbilicus, but so colon sign is umbilicus, and that's the only time I'll accept it. And then we have gray Turner sign is when you turn the patient, you'll be able to see it on the sides, right? That's kind of the mnemonic for those two. Will that help you in real life because you're not going to see it in real life? Maybe. All right. Either way, we have necrotizing pancreatitis, right? And we have an edematous pancreas that we see on CT scan, right? So back in the 70s, 1974, all right, 1974, they had this Ranson's criteria, which sounds like that's like when the the Zodiac killer was also around, right? So the Ranson criteria was what they did because CT scans were super expensive in the 70s. So they say, hey, who should go to CT scan? Because I know that there's a lot of complications, chronic complications over here that can happen when I have a pancreatitis. I need to know when that happens because if they have an infection, they have necrotizing pancreatitis, I need to give antibiotics, right? That's why I know it's time for antibiotics is when I have gangrenous necrotizing cells that are high risk for infection. That's when I should be giving, knowing what's happening. So they had this Ranson criteria. So not only did it tell you mortality, there's 11 different pieces, and if you had 7 of them, you had 100% mortality for pancreatitis. We have we can catch a little bit better today, but it's still a significant mortality when you start having a white count that's more than 16K. That's easy. Age greater than 55, that's already 2 points. 2 points is already a 10% mortality. Right? It's 1 in 10 people that get it will die. Right? And then we have LDH. We don't do LDHs anymore. It's extremely rare that we'll do LDH. ASTs we do though, right? ASTs elevated, that's a gallstone pancreatitis. Right, that's easy, and we got a calcium that's low. We know hypocalcemia can accompany pancreatitis as a consequence of. BUN starts rising. That's really we probably use creatinine would be better, but BUN starts rising. That means I have what involved now? The kidneys are involved. Why are the kidneys involved? Well, A, it's inflammation. Inflammation impairs body processes, but also 2, we got hypotension. And do kidneys like hypotension? No, they're going to freak out, right? So O2 getting low, that I have a systemic inflammatory response. That's going to put me at risk for ARDS, right? Acute respiratory distress syndrome. So our bodies, when your ARDS happens when you have too much inflammation happening, right? And then hematocrit falling, that'd be like a hemorrhagic pancreatitis. But it's easy to get 7 points on this list, right? Base deficit, we don't do base deficits anymore. More than 4. That means bicarb is 22 to 26, 24. If you do -4, that's a base deficit of -4. So your bicarb is less than 20, which could be renal failure, it could be surge response. That's a sign of poor outcomes, right? That's a sign that we have a sick patient on our hands. And then even back in 1974, they said, hey, if you gave more than 6 liters of fluid to this patient, that is a high risk, high mortality. So we knew back then that fluid kills, right? So we knew that it was bad to over-resuscitate a patient with pancreatitis. Okay, did we learn? Not yet. So we still give way too much fluid to these patients. Really, 3 liters is really where you should top it. If you're giving more than 6 liters, that is a really bad sign. We should have done vasopressors well ahead of time, right? It's like definition of insanity. Oh, maybe the blood pressure would be better now if I give another liter. Maybe now another liter. Maybe now another liter. It's like, and then so it should be just you start pressors. That'd be the best option, right? They do have systemic inflammation and systemic hypotension and vasodilation, but to a point, right? We have to start vasoconstricting because the problem is vasodilation. Giving fluids there's no mechanism that says I give fluids that's going to make someone's vasoconstrict. That's not a thing, right? So we have to give pressors to vasoconstrict in the meantime. Okay, all right. So that's our what we're trying to catch are these late complications that happen at like 4 weeks for sure, but you might get it. You'll see about 10 to 14 days in, right? About 2 weeks, you're going to start getting these signs of necrosis that are happening. That puts you at risk for what again? For risk for an infection, right? So an infection can develop with necrosis. With just straight up edema, that's not going to develop an infection. It can get walled off and they form little cysts, pseudocysts. That can happen, but it's not infectious, right? But when you start getting necrotizing pancreatitis after 10 to 14 days, that can then put you at risk for necrosis. It could wall off itself, and now you have like a nice area for bacteria to proliferate. These patients are usually get worse than they get before they get better. So they were sick ahead of time. Again, fluid is not aggressive. It's just going to be up to 3 liters, maybe 4 liters tops. And then after that, we're going to say, we got them resuscitated, they're doing great. And then all of a sudden, like 6 days in, 8 days in, they start getting more hypotensive, they start getting more febrile, and white count starts going up. They start getting this criteria here. That is someone that needs a CT scan in 1974 or a CT scan in 2024, right? We should get a CT scan. Hey, let's look at that pancreas. And you go in there and they say, well, shoot, it's necrotic. So that's when we decide to get antibiotics, right? So antibiotics are given in pancreatitis when they get worse after like 7 days. Okay, they are not given early in the course of someone's pancreatitis.